Hi, my name is Jennifer Shadle, and I'm presenting my research on continuous passive motion following total knee arthroplasty. This is an integrative review. I'm a rural health family nurse practitioner student at Eastern Kentucky University. The clinical problem that guided my research was an intervention peacock question, and it was in older adults with OA who undergo TKA. How does use of CPM compared to not using CPM affect post-operative patient outcomes during the rehab phase, which is approximately about 6 weeks? Evidence to support the problem. It was out there. There's a population of older adults with end-stage OA of the knee joint in which surgical intervention does improve their quality of life. CPM use is still controversial following TKA, and I found now usually it's the orthopedic surgeon's preference, and this should be based on evidence-based practice instead. Data was obtained from the CDC to support my problem, and you can see below that it was out there, and there was a lot of people, older adults, who are affected by OA, and it's actually believed to be a conservative estimate, and in 80% of these people, they do have some degree of movement limitation, and this affects their daily activities. The theoretical framework that I used to guide my theory was the transitions theory, and I focused on the health-illness transition and treatment adherence. The literature review, I chose to search for level 2 evidence, and I did find it for randomized controlled trials, and you can see the names of the journal articles below with the APA citation. In the study by Linson et al., they assessed the benefit of CPM in addition to PT during a short-term stay. They had 40 participants, average age 65. The intervention group again received CPM. 5-day length of stay, outcomes measured on day 4 and 17. In Herbold et al., they assessed the effects of CPM for patients who had initial poor range of motion and then after the TKA to an inpatient rehab facility. They had a large participant group, as you can see. Again, the average age was the older adult. The intervention group received CPM use in addition to 3 hours of combo of PT and OT, and the control group did not receive the CPM at all. You see when the outcomes were measured, and the WOMAC scores was actually a survey that was sent out to patients a week after discharge, and it measured some subjective patient outcomes such as patient satisfaction and pain. Dennis et al., they compared 2 intervention groups to a control group, and the control group had PT alone, and then the intervention group had a varying degree of CPM use. You can see 35 minutes daily and then 2 hours daily. Average age, again, older adult. In Braun et Olson, they decided to determine whether CPM, in addition to active exercises, has effects on these listed patient outcomes, and they are pain, range of motion, time walking, and stair climbing. And this was during short-term rehab. The outcomes were measured initially before the surgery, 1 week post-op, and 3 months post-op. Average age, older adult. Preoperatively at 1 week and 3 months post-op, again, are when the outcomes were measured. So then we can compare even the long-term, as far as like pretty long-term effects of using a CPM machine. In my synthesis of evidence, all of them fell within my 6-week initial time frame goal, besides that one by Braun and Olson, where they did again measure outcomes 3 months post-op, which fell a little bit out of that range, but the other results fell within. And then all of the outcomes were usually measured from day of admission and day of discharge. Linson et al. Showed that their patient outcomes had improvement in pain and passive range of motion with use of the CPM machine on their day 4 measurements. However, it needs to be noted they didn't get CPM machines upon discharge to contribute for day 17. And this information does contrast with the results from Braun et Olson, which pain was not reduced. All their studies had no significant difference in the use of CPM machine compared to therapy alone. Again, standard care CPM is 2 hours twice a day. There are variations among studies, which make it more applicable to real-world conditions. In Herbold et al., participants and therapists were not blinded. This could have led to some biases. Again, no significant difference in patient outcomes with use of CPM in addition to routine therapies. So we could eliminate this burden to treatment adherence for patients by removing CPM machine from the order sets following a TKA. We don't have to bill their insurance for costly equipment, greater patient independence at home. They aren't having to maneuver this bulky machine, and sometimes it's physically uncomfortable. They aren't confined to a bed. for about 4 hours a day. They can participate in more therapeutic activities, and this could be implemented in an inpatient rehab facility or in the home environment.